Hi, Jacqueline. My name is David. I'm going to be your student nurse practitioner today. And today we're going to be doing a couple exams, but we're going to start off with the thoracic exam. Are there any concerns that you wanted to talk about before we go ahead and begin?
Not at this time.
Okay, great. During the exam, I'm going to be inspecting, looking at your anterior and your posterior chest, so your front and your back. I'll be palpating your chest and your front and your back, okay?
Okay.
And percussing you, which just means putting my finger on your skin and hitting it with my other hand, listening for any type of tympany, resonance, or dullness, or flatness. During that exam, I'll have to put hands on your body. Is that okay?
Yes.
Okay. And then finally, I'll be listening with my stethoscope here for your breath sounds, okay?
Okay.
All right. I went ahead and I washed my hands before this exam, so let's get started. Okay, Jacqueline, go ahead and breathe normally for me. All right. At this point in the exam, I'm just going to be looking at her anterior, posterior, and lateral chest. And I'm looking for use of accessory muscles, like the scalenes, sternocleidoid, mastoid, pectoralis major, minor, and the external intercostal muscles. Seeing if anything's breathing in or pulling in that they shouldn't be, because that would be a sign of an abnormal breathing rate in rhythm. So her breathing seems normal to me. It's within the range of normal limits for breathing. She's not trying to breathe labor. It's unlabored breathing. So we're going to go ahead and palpate her chest, okay? And to do that, I'm going to put my ulnar surface on her chest, and we're going to be looking for fremitus, which is vibrations that may be coming from her lungs, right? Okay. So what I want you to do, okay, is I want you to say the word 99. Go ahead and say it for us.
99.
And then I'm going to go ahead and put the ulnar surface, so my pinky side, onto your skin, in between the ribs, right?
Sure.
Your intercostal space, and feeling for vibrations in your lungs, okay?
Okay.
Less vibrations typically, or more vibrations means that there's more space that there should be in your lungs. Okay, so we're going to go ahead and say 99.
99.
Okay.
99. 99. 99. 99. 99.
Okay, good. We're going to go ahead and do your back too. But we're going to do that. We're going to do all the posterior exams when Jacqueline turns around. But for ease of this video, we're just going to do the whole front. When I was palpating you, was there any tenderness you felt on your chest at all?
No.
Okay, good. So then we're going to move on to percussion, okay? And for percussion, I'm going to put my finger, this is going to be my pleximeter finger, I'm going to put it into the intercostal space. So you want to feel it, and you can feel the second rib right here, and then you just go right below this, and so on and so forth down the chest. Then you take your middle finger, and you go ahead and you hit your pleximeter finger, hitting it and pulling it away to not dull the sound. And we're looking for a resonance because lungs are air-filled, so we're looking for a resonance. Any deviation off that resonance is abnormal, and that might show us that there might be something going on that we have to check for. As you can hear, any tenderness when I'm doing this?
No.
Okay. As you can hear, and you can go ahead and put your hand on your head right here. We're going to go along the side. As we get lower, right, to that costral angle right in this area right here, as you move down the midclavicular line, and we hit the fifth rib is right here, as we move down to the costal angle, we're going to feel a dullness, and that is where the diaphragm meets the top of our other organs. So we have this liver right here creating a dullness, and we can feel it if we, which is a lot less resonant than that area. And as we percuss, we hear resonance throughout the, I put your arm down, we can hear resonance throughout the whole entire chest wall, which is a good sign. Okay. Finally, what we're going to be doing is we're going to look for thoracic expansion. We just want to know that Jacqueline's using her whole lungs to expand. And if not, maybe there's something blocking that, or it's abnormal, and we're going to have to look into that. So to do this, we go ahead and put our hands on the chest, and we move our fingers a little bit in. And then when she breathes, our hands come out like that a little bit to show us that they expand. If it comes out unsymmetrical, then we have a sign of abnormal. Okay, Jacqueline, I'm going to put my hands right under your ribs, right? At that costal angle we were talking about, okay?
Mm-hmm.
Go ahead and take a deep breath in for me. As we can see from this exam, my hands separated evenly and came back together evenly, showing that there's no abnormal, that this is just within range. Now, to listen to her chest, there's a lot of different areas to listen to the chest. So I'm going to ask her to take deep breaths for me. And at any point in this exam, if you feel lightheaded, just let me know, okay?
Okay.
Okay. By placing the diaphragm of the stethoscope onto the patient's chest, I can hear her breath sounds. Jacqueline, take a deep breath for me. In a step ladder-like fashion, we progress towards down the chest, listening for any type of wheezing or stridor or crackling that we may hear. We listen laterally too. Jacqueline, can you put your right hand on the top of your head for me? As we know, the right lung has 3 lobes. So in order to hear all of them, we have to listen laterally. And just for symmetry, we'll go ahead and listen to the left side. Okay, good. So we didn't hear any type of breathing that would be abnormal. So we're going to go ahead and move on to the posterior part of the thoracic exam, where basically we will be repeating what we did in the anterior portion. Thank you. Okay, so we had our patient turn around, and on a bed, you want the patient's legs hanging off just like normal, so they're not kind of tensing up their abdominals and maybe hindering your ability to hear any type of breath sounds. So in this case, we're just using a mattress, so her legs are fully on the bed. But we'll do the same thing. So I'm going to inspect. Jacqueline, can you take a deep breath in? Again, we're not seeing any use of accessory muscles, so we're going to move on to palpating for fremitus. By using, again, the ulnar surface. You can use the ball in your hands, but I prefer the ulnar surface to feel those vibrations. And again, we're going to put those ulnar surfaces in between the intercostal spaces, moving down the posterior side of the back. Jacqueline, go ahead and say 99 for me, okay?
99.
As we move down,
99. 99.
we can hear more of those vibrations
99.
as we get closer to the base
99.
of the lungs.
99.
Good.
99.
And they go away.
99.
Once you get past the base
99.
and the costal vertebral angle, right around here, right? So around T9, T10, you're going to put your hands, right, because we're going to test for chest expansion, just like we did on the anterior side. We're going to put our hands right in the back, and you want to take note. You want to move your fingers a little bit closer to see a little skin gap. You want a little bit of skin to just pinch up a little bit, right? All right, so we're going to do that. Jack, can take a deep breath. And as we did that, one more time for the video. So you can clearly see that my hands symmetrically go apart and symmetrically come back in, okay? And that shows that we have equal chest expansion. All right, Jacqueline, I'm going to go ahead and, real quick for me, did you have any tenderness in the back of your, on the back when I was palpating you?
No.
Okay, great. So we're going to go ahead and move to percussion, just like we did the back, right? And the front. Taking our pleximeter hand, finding the intercostal space, listening for that resonance. Just like we listen to the lungs, we percuss in the same manner. We do a step ladder-like fashion. And I'm listening for, go ahead, Jack, and cross your arms for me. We have her cross her arms to bring the scapulas in on both sides so that we can have access to the lungs, because it would be flat sounding if the scapula was too close to each other. So we just go down in a ladder-like fashion. We hear good resonance in the lungs, and right around the 10th thoracic area, when the costal vertebral angle is, we start to hear a more dullness sound as we get to the more solid filled organs down here. So we're going to go ahead and listen with our stethoscope. We're going to use our diaphragm in a step ladder-like fashion. We're going to go ahead and listen from the apex of the lungs down to the bottom, and the apex is all the way up here at the top. Okay. Jack, go ahead and take a deep breath for me. Okay, good. And at any point in this exam, if you feel lightheaded, just let me know. Good, good, good. Okay, and you don't want to forget to percuss over the lateral side of the lungs, seeing that you hear the resonance that we expect to hear. So there's no abnormal findings, so we're going to go ahead and move to the cardiac and circulation part of the exam. So this will be the portion of the cardiac exam where we listen to, and examine the circulation, and we look at and examine the heart. To do this, we go ahead and look at her external jugular on both sides, and we see soft undulations as she lays down. As she stands up and as she walked in, we saw that those soft undulations went away, and that's a good sign that there's no ventricular overload and that her venous system is working appropriately. We look for thrills at the carotid, so heaves and lifts at the carotid. We're not seeing any of that. As we look at the chest, we see that there's no heaves or lifts anywhere. Her heart is beating appropriately. We're going to go ahead and palpate with the palmar surface of her hand and feel the pulmonic and aortic, herbs, tricuspid, the mitral, which leads to the PMI, which is in line with the midclavicular and fifth intercostal space, in the sternal border. We're feeling for any thrills that we may feel in the palmar surface, and we didn't know thrills were felt. So when we palpate the PMI, or point of maximal impulse, that is the apex of the heart, where the ventricles contract and inject all the blood out. So we want to go ahead and feel if that's a palpable area on the body. So we go ahead and, in line with the midclavicular line and the fifth intercostal space, I'll go ahead and feel right underneath. It's palpable, there's no thrills. Okay. So after inspecting and palpating, we're going to be moving on to auscultating, and we're going to use the diaphragm, and we're going to use the bell. And the bell is for extra heart sounds and for bruits. So we're going to be listening to the cardiac exam with the diaphragm first, and then we'll go through with the bell too. As we move to the cardiac exam, we're listening for specifically S3 and S4, S3 being after S2, S4 being just before S1. We're also looking for any extra heart sounds, such as like mitral stenosis, regurgitation, so we're listening for bruits, and aortic regurgitation or aortic stenosis. That will be heard in this exam. Those are all abnormal findings. So we start the exam at the pulmonic area, which is at the second intercostal space, where we hear S2 greater than S1, and that is the same for the aortic on the left side. We move down to the third intercostal space, being Erb's point. As we move down to the tricuspid, which is at the fourth intercostal space, we start to hear S1, which is greater than S2. So it's a clear love-dub sound as I'm listening to Jacqueline's heart. Move to the mitral area, which is at the left sternal border of the heart. In line with that midclavicular line, which we made a landmark when we palpated for the PMI before, we go ahead and put our stethoscope at that PMI portion. And we go ahead and just listen. No extra heart sounds were heard. Before we move on to the bell portion of the exam, I take my stethoscope. I'm going to listen to her carotid for any bruits. No bruits are heard. Bilaterally. So you go ahead and you flip that stethoscope, give it a test, and we move back to the left sternal border, listening for any bruits or extra heart sounds. So you go from the PMI to the mitral, back to the tricuspid at the fourth intercostal space. Again, moving up the left sternal border to the Erb's point. Again, no bruits are heard. Now we're at the aortic. And the pulmonic. And finally, we'll end with the carotid again, listening for any bruits. Okay, good. Looking over our notes, we see that the upper portion of the exam is within normal limits, so we'll be moving on to the circulation part, which is feeling for the pulses. And the pulses of the body, I'll go through them. And you're going to feel bilaterally because you want to find symmetry anywhere you examine the body. So we feel where the bicep ties into the condylar space in the arm, feeling at both points. You want to feel for equal and strong pulses. So we're going to check the radial on either side too. All the pulses so far are +2. Feeling for the femoral pulse on either side, and they're strong and equal. Moving on to the popliteal pulse right behind the knee. Again, always on both sides, just to test and see what's going on with the circulation on either side of the body, and you can test and see if one is normal, maybe the other one feels different. That may be abnormal and cause for concern or just more exams. Moving on to the posterior tibialis pulse. That's at the back of the ankle. And somebody with ankle edema, you wouldn't be able to feel this too well. Also, that could, if the circulation is poor and the venous return is poor, you'll have ankle edema. And for Jacqueline, it's great. No ankle edema is noted. 2 strong pulses on either side, +2. We're going to the dorsalis pedis pulse on the anterior surface of the top of the foot. Strong pulses are felt, +2 on either side. So for this portion of the cardiac exam, I'm going to have Jacqueline lean forward, right? And we're looking for aortic and pulmonic regurgitation or pericardial friction rub, right? And by doing this, we're putting more pressure on the anterior surface of our chest, making that heart sound a little bit more clearer for me, okay? So I'm going to come around on this side for Jack. I'm going to place my stethoscope on her heart with the diaphragm. We're going to go ahead and just lean forward for me, okay? And still I hear on Jacqueline that strong S1, S2 sound. Stronger S2 or S1 up here. Okay, good. Okay, great. So that is the sitting position where they're leaning forward. Next, we're going to do left decubitus position, and that's a great test for mitral regurgitation, and it's also good for palpating the PMI. So we'll get into that position. So, like I said, we're in the left decubitus position, and I'm going to be on her right side. So I'm going to lean over, and I'm going to feel for that PMI that I know where my landmarks are, because I already did this in the laying down in the sitting position. So it's a midclavicular, in line with the midclavicular line in the 5th intercostal space. You want to feel for that PMI. And the reason why we do it in this position is literally the apex, or the point of maximal impulse. The bottom of that left ventricle is felt right here, and it's pressing against the anterior surface of the chest. And that's a pulsation that is not abnormal. So we're going to go ahead and listen. Still, we hear that strong S1, S2, no extra heart sounds. Okay, great. So finally, we had lying, sitting, the left decubitus position. We'll move on to the abdominal portion of the exam. So for this portion of the exam, we are going to inspect, auscultate, palpate, and then percuss. And the reason we do that in a separate order than any other test is because we don't want to disturb our organs down here to maybe give us a false reading of a hyperactive bowel sound. So first, we're going to inspect the chest. We're going to inspect the abdomen. We're looking for any lesions, any skin rashes, anything like that that may be abnormal or indifferent. Her skin is warm, pink, and dry. There's no lesions noted. We went ahead and we're going to put Jacqueline on just one single pillow. Jacqueline has emptied her bladder before this exam, and we're actually going to ask her if she can just bend her knees. And the reason why we do that is because that takes all the abdominal muscles out of the exam. So it doesn't tense any of them up at all. We want her abdomen as relaxed as possible, so that doesn't diffuse any sounds or feelings that we may have as we do the test. So, like I said, let's move on to the auscultation part of it. I'm going to use the stethoscope and the diaphragm of my stethoscope. Right? You might want to heat up your stethoscope too, so it's not cold on your patient. we go ahead and we listen to all of the sounds in the abdomen. We're going to listen to all the vowel sounds. Listen to the 4 quadrants. Actually 5, we're going to listen to the epigastric too. So right upper, epigastric, left upper quadrant, left lower quadrant, right lower quadrant. If you were to hear anything, you might want to listen for longer than a minute or so on each of those quadrants to give you a good balanced exam. So before moving on, we need to listen to the arteries that go down. The arteries that we have are the aorta that travels down. We have the renal, the iliac, and the femoral. So we'll go ahead and listen to all of those with our stethoscope now. So we start with the aortic, go to the renal. The renal is just next to the aortic in the epigastric spot underneath the costal angle. We move down to the iliac, which is near the lower quadrants, in line with the top of the iliac spine. Listening for any brueries. None are heard. Move on to the femoral, where we felt for those femoral pulses. And no brueries or agitation sounds were heard. Okay, after moving on from these arteries and the vowel sounds, we're going to go ahead and percuss the 4 quadrants. Okay, and we're looking for a tympani heard over the gas-filled organs in her stomach. Okay, as we move up closer to the costal angle, we will hear a dullness, and the liver is covered by most of our ribs. So we find that midclavicular line, and where it meets almost the right side of that costal angle, we're going to feel a dullness, and that's when we're going to start moving our way back down that costal angle and down further, and that's going to give us our liver border, which should be sharp, right? And it shouldn't be too firm, but firm. And we want to go ahead and make sure that there's no masses on it or anything that may be abnormal. So we'll go ahead and percuss. As you can hear, all tympani in all 4 quadrants. And now I'm just going to move up the midclavicular line, waiting for that dullness. I can feel the dullness right here, so I'm going to move down and palpate where I feel the liver border, and I can feel that it's a sharp border. And you want to take a measurement of the span of the liver. And Jacqueline's liver is about 7 to 10 centimeters, which is within normal limits. To move on to the spleen, which is on the right side of the patient, you have to put your hand in the back of the patient's ribs, underneath the costal-vertebral angle, to push up the organs. And then you take your right hand and you press here. A lot of people don't have a palpable spleen. If you feel a palpable spleen, that could be splenomegaly. The other way to test for this is percussion. And you want to move down the lateral border of the patient and the anterior axillary line right here. And as you move down, you'll hear a tympani or almost resonance over the gas-filled bubble. But as you move down, you might hear more of a dullness of the spleen if it is enlarged. But for Jacqueline, you can't hear it. Then you want to move on to the kidneys. Kidneys, a lot like the spleen, are most likely not palpable, but you use the same technique, reaching over the patient on the left side of the hand, pushing it up, and almost ballotting to palpate where the kidney is. For Jacqueline, the kidney is not palpable. And the same thing on the left side, on the right side for the right kidney. The right kidney is a little bit higher. Okay. And Jacqueline's kidneys are not palpable. When we move to the 4 quadrants, we are going to be testing for Murphy's sign, which is also known as rebound tenderness. So I'll go through that first. We'll go through a couple different spots. So we'll talk about those spots right now. So Murphy's is rebound tenderness, felt at the left lower quadrant. By pushing down and then quickly withdrawing my hand, if she does have tenderness, that could be a good sign for appendicitis. McBurney's point relating to appendicitis is where the iliac, superior anterior iliac spine is in line with the umbilicus. About 2/3 away from the umbilicus, you have the McBurney's point, which is right at where the appendix is. And if that portion, that part is tender when you press a McBurney's point, that could be a good sign for appendicitis too. So I'll go through that in a minute. Then we'll do the psoas test, and we will do the obturator test. Both tests are signs for appendicitis. So I'll go through the palpating now. So we're going to palpate Jacqueline on the quadrants. Let me know if you feel any tenderness when I do this. And for these organs, you have to do deep palpation. So for this, I'm going to do Murphy's sign over here. I'm going to press down and withdraw. Any pain?
No.
Okay. Then I'm going to move on to the right lower quadrant. I'm going to press down. Any pain?
No.
Move to McBurney's point, which I know is in line with the umbilicus, the iliac, top of the iliac spine. I make that mental line. I have my landmark, and I press down on it. Any pressure?
No.
Any pain? Okay. To do the psoas test or the obturator test, the psoas test, we are going to pick up her leg like this and bring it up. If she feels a tightness or pain when I do that test, she will let me know. Did you feel any pain or tightness?
No.
So then that means that it's a negative psoas test. If she was laying on her back, I would bring her leg up in the air. It's the same type of exam. So we're bringing her leg into flexion. Now for the obturator test, what we're going to do is we're going to bring her knee up, and then we're going to internally rotate her hip. Any pain when we do that?
No.
Okay. And we're going to go ahead and bring your leg back down. And that will do it for the abdominal portion of the exam. For every patient, when you do the abdominal exam, you don't want to forget to do the aortic palpation, right? Because you want to measure for the aortic span, and it's in the costal angle. You're going to be palpating, and you're going to palpate on both sides, and typically it's about 3 centimeters. And for Jacqueline, that's exactly what it is. For the next test, I'm going to be having Jacqueline sit with her back towards the camera so I can test for costal-vertebral angle tenderness, which is a good indication of kidney pathology. And we'll be moving to that portion of the test next. Okay.
Like how I did with the back.
That's exactly right. So for this portion of the test, I'm going to be on Jack's right side, and I'm going to go ahead and put my palmar surface on her costal-vertebral angle, right? So I can feel where it is. Usually it's around T10 right here. And we go ahead and put our palmar surface on, right? And then we take our fist, right? And we slap on either side of it, right? Both sides. And we ask her, do you feel any pain?
No.
If there was pain, that would be indications that there might be some pathology going on with your kidneys, maybe inflammation, anything that could be causing tenderness to that area of the body. So that concludes our cardiac, thoracic, and abdominal exam. We went through the lungs, we went through the heart, and we went through the abdomen, and your test was normal. But do you have any concerns for me today that you want to talk about that maybe were unaddressed during the exam?
Nope, we addressed everything.
Okay, great. If there is any concerns, please just give our office a call.
Sounds good, thank you.
All right.